how do we decide between gradual correction or acute correction? That's my task for today. So I was asked to address what are the implications of each mode of correction, factors to consider, and decision making. So this is the assumption that when you do acute correction, you can do small amounts, it's a limited correction, and you can do with plates and nails, or you can use an external fixator, but generally the attraction of acute correction is that you can do plates and nails, and they can minimize the length changes by doing sort of clever osteotomies. But risk of injury to nerves can be significant. This is what worries, of all the things, this is the worry that they can cause damage. And the attraction of that, this particular side, which is frame, and the motorized nails are coming up, but generally it's less risky. Lengthening is an option. So let's see what factors we need to take into consideration. Okay, this is more relevant for the knee, and we are talking about the knee. Why? Because there are, more common, there are lots of vessels and nerves around it, and, they have a big implication. It's a big nerve. It's not like a sural nerve in foot and ankle surgery, but if you knock off peroneal nerve, it's got big problems. Okay, so, and etiology has an influence. So let's see how we tend to decide. Let's get back to basics. What does angular correction do? It does alter the length depending upon what you do. So this is opening wedge, this closing wedge reduces the length, and this is the neutral wedge, where you can adjust, minimize the length changes, but improve or maximize your angular correction. So if you said, well, this is, let's say this is 15 degree or 15 millimeter base angle, you can do cut half and half and swap over. We'll show you some examples of that. So another factor is that we all talk about bone length, but length again affects everything, nerves, blood vessels, even the ligaments or joint capsule. And you can just trip over in the sense that if there's a flexion deformity, you can make it worse by trying to correct the varus or valgus. So that's very important. Of course, vessels, you can do by twisting, you can wring the blood vessels out of circulation and cause trouble. And a skin problem. Sometimes we've seen from previous surgeries, the skin was adherent at one of the pin sites, and it was the main source of pain post-operatively. This, we all have seen this diagram several times. So that's a sciatic nerve divided into posterior peroneal nerve, and the peroneal nerve winds around the fibula. And that is the main crux of all this osteotomies and what to look after. But if you look into detail, what is important to realize that the peroneal nerve component, which comes up in lower third, it starts to separate, is not as tethered. It is much more mobile. So you have more leeway, more sort of room to manipulate the femur and not worry about peroneal nerve or posterior nerve, except when you're correcting flexion deformities. Now, if you move down the path of peroneal nerve, and that's where the problem is. That short run, taking an angle, and there are lots of structures, like fibrous tissue, that tethers the fibula, peroneal nerve to the fibula, and sometimes previous surgery or an osteochondroma can cause trouble. So, the basis of any recommendation today would be this, that femoral osteotomies, you can be a bit more liberal because the peroneal nerve is not tethered, or sciatic nerve is not that tethered. So this is the question often asked, how much correction is tolerated? How much stretching of the nerve or vessels is tolerated? There's not a single number. If you're doing it gradually, you can do 1 millimeter per day, and the nerve will respond right up to 20-30% of the limb length, so it's not a problem. But it is very difficult to predict how much an acute stretching would cause trouble. It also, not only just angular correction, if you're derotating, or if you're correcting a flexion deformity, they all have implications on stretch. So it's not possible to give a number. So the stretch on the nerve is related to the distance it is from the angular ACA, or angular correction axis. So it's commonly in trouble in valgus to neutral correction, but it is not safe to do big acute corrections of varus. It also stretches the peroneal nerve. So it's a common conception that, okay, if you go from, correcting varus, then it is not, the peroneal nerve is understretched. That's not true. So one has to consider that to how much varus we are correcting. So what are the factors one should consider? Bone factors. So which bone we are correcting? As I said, distal femur is much more easy to do. It tolerates quite a lot of variation, whereas tibia, it doesn't. And magnitude and direction. Of course, we talked about valgus to varus. And of course, soft tissue constraints, impediments, particularly like osteochondroma or a myelinated fibular neck fracture, and all those can cause trouble, will restrict your correction. And of course, if you're expecting additional lengthening as a part of your open wedge or intentionally, then that should be considered too. And other deformities, say for example, as I said, if you're correcting particularly in proximal tibia, in Blount's disease, it's not just varus. There's interrotation, there is also anterior apex deformity. So they all affect the factors that you need to consider. So let's start off with varus deformity correction and see how we deal with it. That's a common site of correction in varus tibia. So this is the number. I looked up all the books and literature. Everybody says 15 degrees is safe. I couldn't find out where it came from, but it makes sense. Knee surgeons constantly do that. That's not a problem. Okay, so 15 degrees is safe. You can correct that. And then if you come to the area of Blount's disease, 15 degrees is nothing. So there is literature to say that you can push up to 30 degrees in selected cases. So that's very pristine cases, no previous surgery, and you're very careful. You've done a generous fasciotomy and a fibular osteotomy, and then you're correcting the varus. So that's okay in some cases. Limiting factors for varus correction is states of the soft tissues. We talked about it. And this is another underestimated. Like we were talking about the ankle, but if you're not careful with the acute corrections, and if the patient has a patellofemoral problem, that can cause a problem too. And if the patient already has flexion problems with bending the knee, sometimes acutely correcting a varus to valgus or valgus to varus can cause trouble, particularly in varus. So those are the factors to be, and of course, if lengthening is needed, then it's a different problem. You can't do this. And do not introduce, while correcting these deformities, be careful. We talked about it, the slope, so do not introduce. So those are all the factors. So let's look at this is common, so you can easily do up to 15 degrees, and it's well proven. Thousands and thousands have been done without major problems. But if you look at Blount's here, this is a large girl, and it measured just around 30 degrees, okay? So I couldn't have put frame on this girl, family circumstances and all, and this is the extreme limit. She's the first, she never had any surgery, and that was it. And I took that chance. Be careful, a generous fibular osteotomy, a fasciotomy here, and I did acute correction. So this is the limit, but you can select right up to 30 degrees. But I'll be very happy, and according to literature, 15 degrees is safe. You can select between 15 and 30, depending upon other factors. So how safe is this? How safe this sort of acute correction varus? In literature, the only thing I found was the study on Blount's corrections. Those are the large corrections. And if you look at it, it's hard to find any comparative studies. The only one study which compared acute to gradual was Edelman's and Sanjeev Madan from Sheffield. They published it, and they compared. It was a retrospective series, so it's hard to say whether there was any comparison. But what they said was, if you do gradual correction, you are up to 1 degree correct, even less than 1 degree correct. With acute correction, you miss that out. But if you accept that, we don't get very accurate correction. So the problems with that is, even in this, you had the compartment syndromes. There was one compartment syndrome out of 328 pooled cases. But if you take out the ones which had fasciotomy, out of 266, only one needed, one got compartment syndrome. But there was a peculiar phenomenon. There were 11 cases of acute peroneal palsy. Remember, we are talking about varus to neutral. Even in that situation, you can get peroneal palsy. But according to this pooled cases study, systemic analysis, they all recovered. They all recovered. So there is that risk. Just be aware. It's not as bad as in valgus, but in varus, when you're acutely correcting, coming up to 30, just be careful. So now we move to distal femoral, slightly safer area. So this is distal femoral varus. The patient had a fracture that collapsed into it. And this is where I use neutral wedge. Okay? You can correct up to 30 degrees, but it will lead to a lot of leg length discrepancy, which patients don't like. So I close the wedge on one side, overcorrected, use the external fixator to hold alignment, reverse that, put the wedge in there, and then that's the play. So you can still do in fever a bit more, but that's an option, open and close wedge. But here, when you have soft tissues, this patient lost his patella. This was a motorcycle accident, completely wiped off patella, and growth arrest resulted in this plastic flap and varus deformity. This will be difficult. Although it was only just 18, 20, I think this is the one you must not correct acutely. It will probably increase or reduce the range of movement in the knee and cause pain or problem. So that's why I chose acute gradual correction using a talar spatial frame and opening wedge correction. So even in varus, where it is safe to do, you have to take those factors into consideration. And this is what we talked at length in a knee talk. So when you have a combined varus, and the total varus between this tibia and femur was nearly 30 degrees. But it's safe to do. In a sense, you do closing wedge osteotomy here and opening wedge osteotomy and get it right. So varus is easy to handle, provided you know the limits of it and the factors that influence it. Now we move on to valgus. This is what worries everyone. Peroneal nerve is at risk. The risk factors are high with tibia and less with femur for the reasons I explained. The nerve is not tethered in that region, so you've got much more leeway. But previous surgery, osteochondroma, they're all important factors to take on board. And if you're doing other corrections, just be careful. So here, this was a resistant rickets lady, nearly 17, 18 years of age, with that significant deformity. So we have valgus deformity on both sides. The magnitude on this side is nearly, it was 30 degrees. I could have done it, but I was worried about this. Young lady, if I could really do some damage to the peroneal nerve, all her life she will be in trouble. So this I chose to do gradual correction, whereas this is in the realm of acute correction. That's not a problem. That's 18, 20 degrees. So I just did use two methods here. That's frame and that's a medial closing wedge. Okay, so this one here would upset knee surgeons. I broke the hinge on the other side. But that will please Hemant, should please Hemant, because I aligned, when you do angular correction away from the chora, it will look ugly. It will look like a dog leg, okay? Nothing against the dogs, but so that's why I did that translation. And actually it's interesting. If the alignment is good, and I've done now, we presented our neutral and closing wedge, 12 cases, all adults. Non-union is not that common. I hear this hinge breaking, but sometimes it's important to get that translation. So if you're doing those large corrections, just be careful. So this is another case, a tibia valga. So this gentleman is a post-polio, but he had tibial lengthening performed when he was a teenager using a Wagner kit. So you can see all those big scars there. And then over time, he was really getting trouble with his foot. It was causing trouble, and already a weak leg, and he was really struggling to walk. This is one you definitely should not correct acutely, because he had previous surgery, and there was lots of scars and tethered. Although this is in the realm of maybe you can push acute correction, closing wedge, but this is not the one to do because of the scars. So I used frame and corrected that. So you could argue forever about where the deformity is. That was just a stitching error. But the patient, I didn't want to touch his femur because he has abductor weakness and he was struggling. So you don't want to touch that part. We corrected the tibia here. And that was well aligned. So. And particularly if you're dealing congenital anomalies, this is fibular hemimelia, had previous surgeries. There was a lot of scarring all around here, and the fibula is dragged down with previous lengthening. And this is one, even though the valgus is not that massive, it's barely 12 degrees or so, use prophylactic peroneal nerve decompression, then use gradual correction. Here, I took a chance to lengthen him as well, although the length discrepancy wasn't that major. So that's one indication. As I said, previous operations on last case, and this is a congenital anomaly. So here we get something like this, combined deformity of tibia and femur, both valgus, and there I divide. The rules don't apply here. So I corrected this opening and closed wedge, so my movement on the femur was very little, 10 degrees on one side, opening wedge, and 10 degrees on the closed side. It was safe to do acutely there. And then this, I did it gradually. I didn't want to take a chance. Again, valgus severus in a large lady. So that's her. She's just come out of frame. So you have to vary depending upon the factors that can influence nerve injuries. So, but now we come to other deformities. Recurvatum is easy. Nothing is under pressure, and that's easy to do with a plate. And then flexion deformities, mainly, James talked about this. So, the flexion deformity, although, I talked about no tethers there, the tether is in the anteroposterior plane. Lots of structures pin the sciatic nerve and posterior tibial nerve and peroneal nerve right to the femur. So if you're doing even, I would say in adults, someone was talking about a patient in ITU, I'll be very worried about the nerves. And from CP practice, when under anesthesia, even stretching after semimembranous semitendinosus release, stretching them acutely on table resulted in foot drop. So it's a very sensitive area. Flexion deformity, always, always gradual correction. Okay? So I use the frame there. So to conclude, for varus deformity, it's okay to do 15 degrees without any concerns. And you can push it up to 30 degrees, I suppose that's in the bracket. Combined femur and tibia, up to 15 degrees on each side, is easy to do and safe to do acutely. With valgus deformity, the rules change. The 15-degree rule doesn't apply. You have to individually evaluate. Even 7 to 10 degrees deformity can cause trouble. Okay, so rules don't apply. Femur is a bit more easy because the nerve is not tethered. And we don't know what the amount for tibia is, but be careful. Take all those factors that we outlined into consideration while doing surgery. Recurvatum, not a problem, the safe thing to do. But flexion deformity, again, just, do it gradually. Okay? Thank you very much.